Welcome back, guys. Let's talk about COVID-19 clinical feature. We will talk about spectrum of severity. We'll briefly discuss case fatality rate. We will also talk about how to manage COVID-19 patient in an outpatient setting. We will do 5 questions in this section. So we'll start with the question number 214. A patient was diagnosed with COVID-19 infection in ER. The reason he was tested because he was having shortness of breath at rest. So he was having dyspnea at rest. You check his pulse oxygen. On room air, it was 92%. You do a chest X-ray in ER. He has bilateral infiltrate. He's having tachypnea on exam. As per National Institute guidelines, how would you classify this patient's illness? Option A, does he have mild illness? Option B, does he have moderate illness? Option C, does he have severe illness? Option D, does he have critical illness? So here the right answer is option C, he has severe illness. We're going to come back to this question. So let's talk about NIH guidelines in next slide. So let's talk about classification of COVID-19 patient on NIH guidelines. So first classification is if patient are positive for COVID-19 test, but they have no symptom, we label them as asymptomatic or pre-symptomatic. Okay. Classification number 2, patient are symptomatic, they have mild symptom, but they have no shortness of breath, they have no abnormal chest X-ray, their pulse ox is normal. We label them as mild illness. So classification number 1 and 2, I have colored them greens, so they have good prognosis. Okay. So most of these patients recover without any treatment. So classification number 3 in yellow, patient who have mild dyspnea on ambulation or abnormal chest X-ray but oxygen saturation more than 94%. So these patients are not hypoxic, but they do have a little bit of shortness of breath on ambulation. They have abnormal chest X-ray. We classified them as moderate illness. So I have shown it yellow because they can get sick. Okay, they need close observation, they might need treatment. We'll talk about that in next couple of minutes. Okay, next classification is classification number 4, patient who are hypoxic, who have low oxygen saturation less than 95%, who are tachypnic, respiratory rate more than 30, or they have lung infiltrate bilateral more than 50%. So these are classified as severe illness. Our patient had a severe illness, his oxygen was 92%, he was tachypnic, he has lung infiltrate, and he was short of breath at rest. Okay, patient who have severe illness, they might have shortness of breath at rest. So classification number 5, patient who have acute respiratory failure, multi-organ failure or septic shock, we label them as critical illness. Okay, so let's go to next slide and talk about our patient. Our patient was hypoxic, bilateral infiltrate, dyspnea at rest. So this patient had severe illness. So option A was mild illness. So mild illness patient who are not hypoxic, who have cough, cold and fever, and who do not have infiltrate on chest X-ray, you can do home management and they can have televisit at day 4, 7 and 10. Okay. Patient who have a moderate illness, these patients might need in-person evaluation in an outpatient setting. We will talk about moderate illness in next couple of minutes. Okay. Severe illness, they need inpatient admission, no question. So mild illness, you don't even have to see this patient, you can do televisit. For moderate illness, they might need evaluation in person in your office. Okay, then you can decide if they need blood workup, chest X-ray or further workup. So we'll talk about that in next couple of minutes. Let's go to next slide and do one more question. Question number 215. We have a 70-year-old male patient. He was tested positive for SARS-CoV in your clinic. So this patient come to your office. He was having symptom. Let's see what symptom he is having. He's having cough, fever, headache for 1 day. So he does not have a shortness of breath. That symptom is very, very important. We'll talk about that, why shortness of breath is important. So this patient have cough, cold, fever for 1 day. You check his oxygen saturation, 98% on room air, which is normal. Blood pressure 130/90, which is normal. Heart rate is good, but patient BMI is 35, so he is obese. You do a chest x-ray, and his chest x-ray is negative. He does not have any infiltrate. He has a past medical history of hypertension, coronary artery disease, CKD stage 3. What would you recommend him? So this patient have mild disease. What would you recommend him? Option A, you ask him to go to ER for inpatient admission. Option B, you start him on outpatient treatment with monoclonal antibody therapy on day 10. You ask him to come back in 10 days if he get worse, and give him antibody therapy. Option C, outpatient treatment with monoclonal antibody therapy now. You start him therapy right now. Ask him, this is what I'm recommending. Option D is you start him on systemic glucocorticoid. So here the right answer is option C, outpatient treatment with monoclonal antibody therapy now. Let's talk about that. So option A, inpatient admission, is incorrect. This patient has mild disease. Patient who have mild disease, they do not need inpatient admission. So the criteria for inpatient admission is either patient who have fourth category of illness as per NIH guidelines, who are hypoxic, who have bilateral infiltrate, who are tachypneic, they need inpatient admission right away. Or patient who have moderate illness, who have significant risk factor. For patient who have mild disease, who are immunocompetent, our patient is immunocompetent, so he does not need inpatient admission. So option A is incorrect. Let's talk about option D, systemic glucocorticoid. This option is incorrect. There's no evidence that steroid benefit patient without supplement oxygen requirement. We typically give steroid patients who are admitted in inpatient setting. We give them decadron, but steroid has no role in patients who have mild disease, who are not on oxygen therapy. Okay. Now let's go to next slide and talk about monoclonal antibody. So in this table, I have given you 3 monoclonal antibody. So monoclonal antibody are FDA approved for emergency use. So these 3 antibody, so number 1 antibody distribution was stopped on June 25th because of gamma and beta variant. So this antibody is not effective against those variants. So now we are using, in US, we are using antibody 2, REGEN-COV. And the third antibody is sotrovimab. This antibody is identified in 2003 from SARS-CoV survivor. Okay. Now this number 3 antibody was first approved in UAE. FDA has also approved this antibody. So these 3 antibody you can use in outpatient setting in a patient who have mild disease, who have significant risk factor. Okay, significant risk factor for progressing to severe disease. Let's talk about that. Let's go to next slide and talk about SARS-CoV-2 genome. In order to understand why are we using antibody, we have to understand the structure of the virus. So let's talk about structure of the virus in this slide. So SARS-CoV-2 genome encode 4 major protein. The first protein is spike protein. It has 2 units, S1 and S2. The second protein is envelope protein. The third protein is membrane protein. And the fourth is nucleocapsid protein. Out of these 4 protein, I'm going to focus on spike protein in next couple of minutes. Okay, we are not going to talk about envelope, membrane or nucleocapsid protein. So let's go to next slide and talk about how does SARS-CoV-2 enter human cells. So SARS-CoV-2 enter into cells by binding with type 2 pneumocyte after binding to ACE2 receptor via S1 protein. So we have ACE2 receptor in our alveoli, and SARS-CoV-2 S1 unit bind with these receptor and enter into human cells. Okay, once S1 protein, spike protein, S1 subunit bind with ACE2 level, this initiate a change in S2 that result in virus and host cell membrane fusion and virus entry. So this is the basic mechanism how virus enter human host cell. Okay, can we block this step? Answer is yes. How do you block? So monoclonal antibody, they block virus ACE2 interaction and they inhibit virus entry. Okay, so now this blue arrow, if you see, these antibody, basically these can block the entry of virus by blocking this interaction of S1 and S2 protein with ACE2 level. So this is the basic mechanism of monoclonal antibody. Okay, so let's go to next slide and see how we use monoclonal antibody in United States. So COVID-19 treatment panel recommend two antibodies. Number one is REGEN, which you can also use for post-exposure prophylaxis for high-risk patient. And the second is sotrovimab. This antibody were identified in 2003 from SARS-CoV survivor. They were first approved in UAE. FDA has also approved it. So let's talk about how to use these two antibodies. So these are used for non-hospitalized patients with mild to moderate COVID-19 infection who are at high risk of clinical progression to severe disease. You should use it as soon as patient tested positive or within 10 days of symptom onset. If you're going to delay the treatment, this therapy is not effective. So you want to use it as soon as patient is tested positive, or you can use up to 10 days after symptom onset. The efficacy would be low if you're going to use it later on. Okay. So there are 5 conditions that represented in clinical trial which can cause severe COVID-19 disease. So those 5 conditions are: number 1, if patient is obese, BMI more than 30. Number 2, if patient have diabetes. Number 3, if patient have coronary artery disease. Number 4, patient who have chronic lung disease. Number 5, patient who have age more than 65. If patient have any of these 5 conditions, and if they are in an outpatient setting, if they have mild to moderate COVID-19 infection, you can offer them these investigational antibody therapy. So in US we are using REGEN-COV. You can give them. Okay. Apart from these 5 conditions, there are other conditions which can which might indicate severe disease. Those are malignancy, immunocompromised status, if patient who have a sickle cell disease. So those conditions are not well studied in clinical trial. If patient have those conditions too, you can also offer them these antibody if you are monitoring them for mild to moderate disease in an outpatient setting. Okay, so let's go to next slide and talk about question number 216. What percentage of people confirmed to have COVID-19 infection develop mild to moderate symptom? Option A 10%, option B 30%, option C 80%, option D none of the above. So here the right answer is option C. 80% patient who have confirmed COVID-19 infection usually have mild to moderate disease. Okay, severe and disease and critical disease is 10 to 15% patients. So we'll talk about that. So in order to understand this question, we have to go back to our table. So classification based on NIH guidelines. So in this table you have 5 conditions. So in this table, we have classified COVID-19 infection into 5 classes. So patient in class 2 and 3, mild to moderate illness, most of the people, 80% of the patient have mild to moderate illness. Usually they don't require treatment, they recover on their own. You can give them monoclonal antibody if they have high risk conditions, okay? So let's go to next slide and discuss this triangle, okay? This is very, very important. So at the bottom, I have shown you the green. So green are asymptomatic or pre-symptomatic infection. These patients have good prognosis. Studies have shown 10% or up to 50% patient might be asymptomatic or pre-symptomatic, okay? What about mild disease, the yellow one? The mild infection patient do not have any shortness of breath, they are not hypoxic, they do not have any abnormal chest X-ray. What about moderate illness? These patients have shortness of breath or abnormal chest X-ray, but they are not hypoxic. The red one is severe. These patients have hypoxia less than 94%. They might be tachypneic. They might have more than 50% infiltrate on chest X-ray. And the last one is critical ill patient who are in respiratory failure, septic shock. So let's go to next slide and talk about fatality rate, okay? Infection fatality rate make more sense as compared to case fatality rate. We'll talk about that. The case fatality rate only indicate the mortality rate among documented cases. On the other hand, the infection fatality rate has been estimated to be between 0.15 to 1%. So let's talk about this concept, why infection fatality rate is more important than case fatality rate. So let's go back to our triangle. So if you take all patients, including asymptomatic as well as pre-symptomatic, and if you can study the death in all infection patients, which is not possible, it would be around 0.15 to 1%. So let me give you an example. So if you have 1,000 patients with COVID-19 infection, out of those 1,000, 100 to 500 might have asymptomatic or pre-symptomatic infection. So if you include that, the case fatality rate would be around 1 to 10 in 1,000 COVID-19 patient. But it's very hard to find asymptomatic patient. So if you just check mortality rate among symptomatic patient and COVID test positive patient, it would be higher as compared to infection fatality rate, okay? So let's go to next slide and talk about question number 217. There are no specific clinical features that can distinguish COVID-19 from other viral respiratory infection. Is that true or false? This statement is partially true. It's very hard to distinguish COVID-19 infection from flu or other viral infection. So let's talk about this question. Let's go to next slide. The range of symptom was illustrated in a report of over 370,000 confirmed COVID-19 cases. Cough was present in 50%, fever 43%, myalgia in 36%, headache, dyspnea, sore throat, diarrhea, nausea, vomiting, okay? So now the last point is loss of smell or taste. This is seen up to 10 to 20% patient. This is specifically seen in COVID-19 patient. These symptoms are less common in other viral infection. So let's go to next slide and talk about 5 most COVID-19 symptoms. This data came from COVID-19 symptom study, a project that tracked self-reported COVID-19 symptom among more than 1 million people in UK. So if you see patients who are fully vaccinated, their most common symptom is headache, runny nose, sneezing, loss of smell, and sore throat. Patients who are fully vaccinated, typically they don't have cough. Now patient at the bottom, if you see partially vaccinated and unvaccinated, they can have cough. So these are the 5 most common symptoms in fully vaccinated and partially vaccinated patient. So let's go to next slide and discuss this this diagram. So if you see COVID-19 infection, you can divide clinical manifestation into 3 phases. First stage is early infection, the second stage is pulmonary phase, and the third stage is hyperinflammatory phase. So first stage, early infection, typically happen within 5 days, and this typically represent viral replication in human body. Okay, pulmonary phase, that is stage 2, and hyperinflammatory stage 3, these represent host immune response to virus. So this makes sense. If you have a patient who have a COVID-19 infection, their viral load keep on going down, and after 10 days, after the onset of symptom, after 10 days, you might not be able to detect viral. And if patients are still sick, that is because of their own inflammatory response. Okay, so if you see stage 2 is critical. In this stage, once virus start affecting lungs, these patients can have shortness of breath, which is a very which indicate patient might gonna develop severe infection. In pulmonary stage, patient will have tachypnea, hypoxia. If you do chest x-ray, they might have more than 50% lung infiltrate. So patient who have a mild infection, usually they don't have pulmonary phase or pulmonary stage. Okay, let's go to next slide and do question number 218. We have already discussed this question in last couple of slides. Coronavirus bind to which protein of host cell? Option A, sialic acid receptor. Option B, ACE2. Option C, renin. Option D, none of the above. So here the right answer is option B. Coronavirus bind with ACE2 level. So let's talk about this question. Let's go to next slide. Angiotensin receptor blocker or ACE inhibitor used in COVID-19 patients. This concept has been discussed widely because coronavirus bind with ACE2 receptor. There are observation studies which have done to find out if patients are taking ACE inhibitor or ARB inhibitor, should we stop this medication or not. Okay, so let's talk about this concept. ARB and ACE inhibitor inhibit the renin-angiotensin system, and it can affect ACE2 level in your body. Okay, when the SARS-CoV bind with ACE2, it prevent ACE2 from performing its normal function, and it also regulate angiotensin 2 signaling. However, randomized trial and observation report found no evidence of harmful association of ARB or ACE with adverse COVID-19 related outcome. So if patient have hypertension, if they are using ACE inhibitor or ARB inhibitor, you're going to continue these medication because there's no harmful effect found in randomized control trial as well as observation studies. So let's go to next slide and discuss the difference between SARS-CoV-2 and flu. So SARS-CoV-2 has a single-stranded viral RNA. Flu virus has 8 single-stranded negative sense viral RNA fragment. SARS-CoV-2 is covered in spike protein which bind with the ACE2 level. On the other hand, flu virus has hemagglutinin and neuroaminidase which enter and exit host cell. Now these receptor in flu virus, they bind with sialic acid. That's how they gain entry to host cell. Okay, let's go to next slide and discuss few differences between COVID-19 and flu. Incubation period of COVID-19 is 2 to 14 days. For flu, it is 1 to 4 days with abrupt onset. Okay, now incubation period for COVID-19 will vary depending on viral load. So if person has exposed to high viral load, they can have symptom immediately. Okay, case fatality rate of COVID-19, I already talked about that, 0.15 to 1%. For flu, it is 0.09%. R0, we did talk about COVID-19, R0 is 2 to 3, but Delta variant is up to 8 to 9. For flu, it is 1.3. hospitalization rate for COVID-19, it could be anywhere between 10 to 20% because 10 to 20% patient can have severe COVID-19 infection. For flu, it is 1 to 2%. Highest risk for COVID-19, old age, whereas flu, children less than 5 and old age both are affected. So with this slide, we are done with this section. In next couple of minutes, we're going to talk about how to make a diagnosis of COVID-19 infection, how to treat COVID-19 infection in an inpatient setting. Then we'll talk about vaccination. So I'm going to stop it here. Thank you.